I'm very fortunate in being the elected independent chair of Newcastle Bridges CCG, which is a clinical commissioning group that is very committed to a social model of health and recognise that the circumstances in which people live their lives contributes to health outcomes. And on the back of that, we were fortunate to get funding from Nesta for their people-powered health programme for long-term conditions. And I like overarching frameworks which help you to think through where you are. And this notion of co-production, I think, is very important for public health. It's come out of co-production around long-term conditions and recognising people with long-term conditions as having assets and building on their assets rather than just looking at them as a disease. But I just wanted to explore this with you in terms of looking at co-production models for public health and being able to think through this whole notion of partnerships and how partnerships work. And I've just changed one or two words here. You know, I pinched these straight from Nesta, and if you want to go to the Nesta website and look at people-powered health programs, it will give you more detail. But actually just looking at these, recognising patients as assets, recognising local assets in terms of public health, well, that's where you need to start. What have you got in your patch? What are your local assets? And to accept that was really what Kate was saying earlier. Building on wider capabilities. In long-term conditions, it's building on people's capabilities, but wider capabilities, what are the wider capabilities within your patch? How can you build on those wider capabilities? Because you're not going to be able to deliver public health outcomes on your own. You need to look at what else is out there and who's actually contributing to public health. Promoting mutuality and reciprocity, it's not just about how you're going to deliver your public health outcomes, but a bit like Kate earlier. How can I help you with your outcomes, be they social care, be they NHS, rather than just thinking about your own outcomes? How do you get the overlap between the outcomes? Developing support networks for people with long-term conditions is clearly important, because actually that mutuality and support that people get with long-term conditions, understanding, being able to help one another is important. You need to do the same sort of thing with public health, developing support networks for your local public health champions within your patch, be they health visitors, environmental health officers, whoever. But you need to build that support network for those people, and you need to engage with them. Breaking down barriers between professionals and users is the long-term conditions. I've just changed that between professional tribes, because we are talking about a lot of tribes out there, and they don't always get along, and we need some sort of facilitative leadership out there in terms of how do you bring those tribes together so that they're working more effectively and delivering more than any of them can deliver on their own. And that final one, facilitating rather than delivering, it's not about what you do, it's about what you actually deliver yourself. It's about facilitating the local system and making sure the system works. And in terms of what we're doing in Newcastle around long-term conditions, it's about facilitating and looking at a lead provider model with the third sector around sort of scaled up social prescribing for people with long-term conditions, natter groups, physical activity, a whole range of things. And it's about a generic approach to long-term conditions, because people with long-term conditions have more in common than they have differently in terms of whatever their particular condition might be. Who do you need to co-produce with? Well, I'm sure you can add to that list. I've just picked out some of them that we perhaps haven't paid as much attention as we might today. Third sector is, for me, obviously important. I've migrated from the NHS and now spend all of my time in the third sector. Healthworks Newcastle, 71 staff, annual turnover of 1.5 million, 20 health trainers. It's an asset in terms of local public health delivery. And third sector, trust, reach and credibility is very important. And if you're really going to address inequalities, think about Cyrenians, think about Age UK, think about a whole range of local third sector organisations within your patch and how you're going to work with them more effectively. Workplace health we haven't really talked about, but workplace health, important setting, need to think about that, stress in the workplace, whole range of issues there. And how are you going to work with your local media? I haven't talked very much about that in terms of your local media is an asset in terms of what are the messages you want to get across, how are you going to get those sort of stories in the media, are you going to meet on a regular basis with the editor of your local paper and think about how you do that. Barriers. And again, I pinched these from Nesta around long-term conditions and co-production. Commissioning and purchasing processes. Good example around commissioning and purchasing processes. Think about obesity. Yes, there's a randomised controlled trial that demonstrates that Slimming World is more effective than standard GP care. They don't actually tell you what standard GP care is, and I've always struggled a bit with that notion of standard GP care because I'm not sure there is such a thing as standard GP care. But there is an issue there in terms of, well, if that's the evidence, shouldn't we all be commissioning Slimming World? Well, is that the best way forward? Or actually, haven't you got people out there who should be doing this anyway? And shouldn't you actually be making sure your GPs are doing whatever Slimming World is doing? Because they're part of the system, and actually you should be doing it within the system that exists rather than needing to buy in from outside. And there are those sorts of issues about how we commission and the whole procurement agenda that does make some of this quite difficult around local assets. I mean, we've moved to a lead provider model because actually there are a whole lot of very small local voluntary sector organisations who don't have the capacity, don't have the ability, don't have the understanding to be able to compete for tenders. But actually, if you look at a lead provider with subcontracts, it's a private sector supply chain model, then you can begin to build that in. But actually that requires commissioners to think through how they're going to commission for those sorts of supply chains and where the risk is going to be carried in those sorts of supply chains. And so it's a whole new ball game basically. Organisational culture and staff skills, well, we certainly need to scale that up and we need to do that more systematically. And we need to spread the word around sort of staff skills. And that final one, measuring and accounting for the value of co-production approaches, I mean I think that's a very difficult one in terms of if you make savings, where do the savings go in terms of that approach? Who gets them? Does the NHS get them? Does the local authority get them? Does the lead provider get them? And how do you actually share out the reward across a complex whole system so that everybody feels valued and feels that they've made a contribution rather than sort of somebody sort of sweeping that all up and taking all of that. So that's me, that's my 4 slides, just as a framework for you to think about the next session.